Good morning, everybody. This morning I have the privilege of introducing Dr. Emmanuel Taban again. He is a leading pulmonologist in South Africa, now known for his groundbreaking contributions to respiratory medicine. He specializes in treating complex lung diseases and gained international recognition during the COVID-19 pandemic for pioneering the use of bronchoscopy to improve outcomes in critically ill patients. His work has saved numerous lives, earning him a spot among the 100 most influential Africans in 2020. Dr. Taban currently serves as director of the Lung Institute, continuing to advance care in lung-related illnesses.
Thank you, Kian. Kind introductions. Today, our discussion we're going to be last presentation. We discussed about vasculitis, but was really more related to ANCA-associated vasculitis. And I thought perhaps at the beginning of 2025, if we could complete the discussion on vasculitis. And this point, we're going to look at other causes of vasculitis. And what I want to allude to, most vasculitis, unfortunately, will present with what we call alveolar hemorrhages. So we're going to approach them in the term of the diffuse alveolar damage and look at the causes. So what's the diffuse alveolar hemorrhage? Of course, it's a syndrome describing the accumulation of intraalveolar red cells originated from alveolar capillaries. And then it's obvious what it does. It results from disruption of alveolar capillary basement membrane. And the disruption is caused by injury or inflammation of the arterioles, venules, or alveolar septals of the capillaries. And if you look at these slides, this is histological of the alveolar from the biopsy. That's your normal alveolar. And of course, you can see in the endothelia and epithelia. And of course, your alveolar septum. And then of course, you do also when you have diffuse alveolar damage, the exposition of the bloods into the alveolar space. And diffuse alveolar hemorrhage, or what we call the H, clinical presentations, they tend to present hemoptysis in 70% of cases. However, in 30%, there will be absence of hemoptysis. And they tend to have a symptom of progressive dyspnea and hypoxemia, non-specific symptoms like cough, and of course, acute severe respiratory distress, requiring immediately ventilation, support with mechanical ventilations, and can be very fatal. And of course, they will have a dropping or low HP, and that's normally requires serial measure of HP on the blood gas. And they can also have clinical features of diffuse alveolar infiltrates on chest X-ray or CT scan. And if you look at the X-ray here, in this patient especially, I think my classifier doesn't work, but if you look on the X-ray on the top, on the left side, you haven't quite this increase in the alveolar opacity, with kind of really quite more, if you look more whiter, and that compared to the left, which right, which is dark, and on the CT scan, it's quite clear. And then on the lower, you see that actually the hemorrhage has organized, and there's some element of chronicity. So how to diagnose diffuse alveolar hemorrhage? What we do in our setting, we do bronchoscopy, and this is how the lungs look like. When you go, you see the trachea, larynx up there, you go bronchoscopy down, and then of course the bronchus are divided into the main bronchus and the segment. So what you do then, you have to look where the blood is coming from. And then what you do, you install saline in and you kind of lavage it. Okay, you need to get about at least 50 to 60 mils. You send to the lab and the diagnosis confirmed when there's more than 20% hemosiderin-laden macrophage. And if you look at the common cause of the pulmonary capillaries, injuries, and most of them, the commonest cause will be your immune-mediated, and the causes are really quite a lot of them. So basically it means every rheumatic disease can cause diffuse alveolar hemorrhage, and that would be from mixed connective tissue disease, antiglomerular basement membrane, what we call Goodpasture's disease, isolated pulmonary capillaritis, that would be ANCA-associated positive, polymyositis, primary antiphospholipid, antibody syndrome, which will be discussed further. There will be a presentation on that. Rheumatoid arthritis, systemic lupus erythematosus, and systemic sclerosis. And then drugs such as carbimazole, that is used for treatment of hyperthyroidism. And then obviously looking at the things like hydralazine that we use commonly in treatment of the blood pressure. and proper uresols. I think this is a drug that I've heard throughout my career, but I haven't even seen it. It's supposed for treatment of thyroid. And then the new kids on block, of course, the TNF alpha antagonists that we get to see treatment of cancers, rheumatoid arthritis, and other autoimmune disease, includes skin problems. Systemic vasculitis, of course, which I alluded to it previous on my discussion, Behçet syndrome, cryoglobulinemia, which I'll touch on it later on my next presentations, and granulomatosis with phalangitis, previously known as Wagner's, and then the most important is the enoxonla purpurea, and IgA nephropathy, which is quite very common in males, and then microscopic phalangitis. Others would be those with a bone marrow transplants, infective endocarditis, and isolated pulmonary capillaritis, ANCA negative, and of course, ulcerative colitis, which is quite very common in the population. Blind hemorrhage, pulmonary hemorrhage, what we call capillary stress failure. So this patient really had no injuries on their capillaries. Their capillaries are actually normal. There's no kind of pathological process that injured the capillaries, but then just the capillary failed based on the stress that's been exposed to. And the common cause of the blind hemorrhage, of course, will be connective tissue disease, such as glomerular basement membrane, Goodpasture syndromes, systemic lupus. So if we bear in mind, the two conditions can cause blind hemorrhage and also immune-mediated drugs, anticoagulation therapy, and anticoagulation therapy, we look at warfarin, but of course the new drugs, like the new oral anticoagulants, they also might be the caprates. So we always have to review our anticoagulations in quite more details. Platelets, glycoprotein 2B and 3A inhibitors, I think those are common, and others will be conditions such as thrombocytopenia purpurea, like ITP, TTP, and HERS. And those who, I think, just to refresh your mind, ITP, obviously, you have immune thrombocytopenia purpurea, and normal, that's where they tend to really present with thrombocytopenia, with a normal INR and normal kidney functions, and that they might have elevated LDH or not, and they're not infection related, and it's really moderate to connective tissue disease. While TTP is a syndrome where it's really characterized by 5. If you remember your medical schools, you look at the renal failure, you look at the thrombocytopenia, increased LDH, confusions, and of course, normal INR. And those patients have high mortality, and of course, they will have what we call red cell fragment also. HERS is similar to really ITTP. The only absence was really the confusions, and what's absent obviously is the otherwise everything really okay. I think the same. The confusion isn't there, and it's mostly really more renal. And HERS is really the trigger tend to be more infectious, especially gastroenteritis, where there were certain strain of E. coli and Shigella. And of course, idiopathic pulmonary hemosiderosis, which I'll discuss later, mitral stenosis, which I will probably give you a video pathophysiology, depending on if it's acute besides chronic, and then pro-myelocytic leukemia that can also cause diffuse alveolar hemorrhage. So this is really supposed to be the normal pathophysiology in the normal people with underlying left heart disease. If you look at that lung remodeling in left heart disease. So if the process occurs slowly, with time, the lung can adapt to it and to develop mechanisms to protect itself. So normally what happens in left heart disease, there's increase in the what we call increased lung capillary pressures because of backward diffusions. And there's also then that leads to mechanosensitive endothelial dysfunctions, increased capillary permeability with decreased fluid reabsorption. And then you get bronchial congestions, and most of these patients present paroxysmal dyspnea. And the normal dyspnea where and also autopnea, when they lie flat, they tend to sit up, and they tend to wake up at night because they couldn't breathe. Acute, of course, they can present acute where there's repair and restitution and integrum. And then chronic form, of course, when the process persists for longer than expected, and of course, with no treatment being given to the patient can develop what we call endothelial dysfunction, myelofibroblast proliferation, alveolar wall remodeling, and of course, pulmonary vascular remodeling. And that leads to increased pulmonary vascular resistance with alveolar wall thickening, and we call that pulmonary hypertension. And then you've got protective, where they decrease edema, pulmonary edema, and maladaptive, where they have restricted lung syndrome, reduced gas exchange, and pulmonary hypertension. Let's go back to it. Exercise-induced pulmonary hemorrhage in birds. I mean, these are horses that are used for gambling and or for racing purpose. And most of these horses really, they run their heart out, and as a result, their capillaries give up. And normally after a race, without knowing, you find that they actually bleed from the nose. It's just because of the stress that's subjected to the capillaries, the lung for gas exchange. And of course, patients that also do develop stress hemorrhage are those patients that they underwent hematopoietic stem cell transplant. And what's common on those patients that the hepatic episodes really linked to the inflammations with cytokines. Sometimes the drugs that are used to prepare the patient for transplant or just chronic inflammations. And most of these patients present with hemorrhage. And here I told you that those patients that have been on steroid, they tend to be much better off than those who actually were not treated on the steroid. Immune-mediated, again, if you look capillaritis, which is, I mean, you look at capillaries, injury to capillaries, and then when there's no capillaries, that's how your normal capillaries should look like. So what are the common causes of the pulmonary capillaritis? The common would be a microscopic pharyngitis, which was on the previous lecture, and grammatosis fluid for anxieties. So you always must check for ANCAs when patients having diffuse pulmonary hemorrhage. Rare cause would be Sachs-Strauss syndrome, what is now known as EGPA, and of course, anti-glomerular basement membrane disease. Capillary is not a predominant feature, but it does present. IgA vasculitis, such as Henoch-Sundler purpurea, which I think during my training, I was fortunate to see one child, and they tend to have present with vasculitic rash on the legs. And otherwise, they're ANCA negative, and sometimes they're difficult to diagnose conditions. But most of them will have acute glomerulonephritis and develop end-stage renal disease. Secondary vasculitis, of course, will be a systemic lupus erythematosus, rheumatoid arthritis, antiphospholipid syndrome, and cryoglobulinemia. Drug-induced vasculitis, as I mentioned, the commonest things that everybody tends to use is allopurinol, gout, which is a disease also people that have a bit of money and can afford wines and dry meat. Then, of course, you're looking at isolated pulmonary capillaritis. So diffuse alveolar hemorrhage in patients with ANCA-associated vasculitis, as in GPA and PA, occur 25 to 27% in ANCA-associated vasculitis, and tends to have really severe disease, often accompanied by rapid progressive glomerulonephritis, best predictor of respiratory failure, with your SpO2 FOV ratio of less than 450, but most of the time I'm really looking at 150, which is what we call severe ARDS, and most of these patients requiring ventilations. And CRP tend to be elevated, and most of the time they're mistaken as sepsis pneumonia, but PCT should be less than 0.1, 0.5. And of course, it's elevated neutrophil, or more than 30% on bronchoalveolar lavage. And if you look at the CT scan, there's diffuse alveolar spaces that are filled with the hemorrhage. And this patient, if you do lung functions, you find that they have increase in DLCO, diffusion of carbon monoxide. You know, it's never low, which is in the interstitial lung disease, the DLCO tend to be quite lower in contrast to that. So there's quite a nice systemic review of diffuse alveolar hemorrhage in lupus, and most of these patients will present with common such as nephritis in 73% and low complements. That's the giveaway. So when you see a patient, so you test for double-strand DNA, complement ESR, and again, you will find that they might have actually urine on the blood. So that will probably give you away, and they might have features of kidney failures already. And then those people, they tend to respond to corticosteroid, higher dose of solimedrol, cyclophosphamide induction is very important, and plasmapheresis. As in previous discussion, we did mention that there's no role of the treatment of vasculitis with the plasma exchange, except when there's a renal involvement. Let's have a look at antiglomerular basement membrane disease. I hope one day I will be able to see one. I haven't seen one up to now throughout my career, but nephrology is probably much more frequent. So with the antiglomerular basement membrane disease, where there's antibodies against NC1, domain of alpha-3, chain of type 4 collagens, limited to the lungs and kidneys. And type 4 collagen is quite prevalent in the lungs and also in the nephrons. And then anti-GBA antibodies are usually IgG, with IG1 and IG3 subclass predominantly. And anti-GM antibodies are typically polyclonal. So, and there's always, most of the time, there's activation complements where there's autoantibodies binding to the GB, to the glomerular basement membrane, causing damage by activating your complement system. And then genetic susceptibility is a rare cause of familial antiglomerular disease have been reported. So it can be familiar, but very rare cases, few cases being described. And antiglomerular basement membrane disease has been also recognized in other white individuals, mostly white individuals and Asian individuals. In Africans, it's very rare, and that's the reason perhaps we're not seeing much in South Africa. Of course, environmental factor, and then of course, antibodies are pathogenics, means can transfer and cause disease in animal, removal, improve disease. So basically what it means, if a patient presents with antiglomerular basement membrane, you cannot do plasmapheresis, you remove them and the patient improves. So you just need to remove them and they actually get better. Environmental factors as smoking, inhalation, toxic may be triggers, and severity of renal disease and diagnosed determine the prognosis. The treatment, steroids, cyclophosphamide, and plasma exchange. Alternative, rituximab and microphenolate. And idiopathic pulmonary fibrosis is one of the conditions that I hope one day I'll be able to make a diagnosis of that, or maybe we miss them. Difficult to say, but it's very rare. And it's a diagnosis of exclusion and no evidence of capillarities. Means the capillary should not be inflamed, and obviously that can be determined from the biopsy. A structural defect in the alveolar capillaries, either in alveolar basement membrane or in alveolar endothelial cells. And this is really caused by accumulation of free iron in pulmonary cells and tissue, which induce formation of highly toxic free hydroxy radicals that can eventually lead to cell necrosis and tissue remodeling with pulmonary fibrosis. Recurrence, they tend to present with recurrent hemoptysis and ground glass infiltrates on the high resolution CTs, anemia with iron deficiency anemia. And then there's a blind hemorrhage, histopathological, where the fibrosis is common in chronic recurrent cases, and predominantly tend to be in children, 20%, and then adults only 20%, between age of 20 to 40, but there are few cases reported in adults more than 83 years old. Treatment tend to be glucocorticoids and immunosuppressive agents. While the Lane-Hamilton syndromes, they tend to have association with celiac disease, and they need gluten-free diet as part of the treatment. And this is really an approach to, it's very tiny slides approach to the idiopathic pulmonary fibrosis. And I really don't want to go to that, but the most important is that it's a diagnosis of exclusion. You have to look for the causes of the other causes of pulmonary hemorrhage from the complete blood count, ANCAs, autoimmune workup, and the glomerular basement membrane, and everything. You have to check for that. And if they're negative, then hence you can't be able to make that diagnosis. Paraglobulinemia, vasculitis, and I remember that when we Steve Biko, I was very intrigued about the paraglobulinemia, and I used to really try to look for it as a registrar. And I would be coming out, and you have to draw a lot of blood, put them in the sand, and it's supposed to be warm, and it's crazy. But I never seen one up to now. But actually, basically, what it doesn't mean that if you don't see one, doesn't mean that it's not going to present. We only diagnose what we know. So I think it's important to have the knowledge. So I just want to go through quite a few terminologies about paraglobulinemia, vasculitis. Paraglobulinemia is a cryoglobulins that they normally tend to be IgG, it's serums in the serum that precipitate in vitro at temperature below 37 degrees and redissolve on rewarming. And that's really the image show you that. On the left, it's when they're precipitated. On the right, when they're being warmed. Cryoglobulinemia refers to the presence of cryoglobulin in patient serum, and cryoglobulinemia vasculitis is a systemic inflammation syndrome that generally involves small to medium vessel vasculitis due to cryoglobulin-containing immune complexes. And then cryoglobulinemia, of course, and terminology still. There's a mixed cryoglobulinemia, and those are the cryoglobulinemias that contain more than one immunoglobulin components. And hyperprecocity syndrome, of course, is a hyperprecocity syndrome that may be present cryoglobulinemia due to hematological malignancies and monoclonals, IgGs. And then Malthus triad, it's referred to the clinical triad of palpable purpura, arthralgia, and weakness. And that, unfortunately, most of these people, they've been diagnosed as a proper thrombocytopenia or what we call the hematological problems. And most of the tests have been more, sometimes you find that those people have been diagnosed as either as von Willebrand disease or sometimes as rheumatoid arthritis without actually looking into the cause. And most of because people don't have the knowledge about cryoglobulinemia as one of the causes. And cryoglobulinemia, of course, is classified into 3 types based on the types of immunoglobulin it contains. So you do have type 1, a single isotype or subclass of immunoglobulin used at IgM, and then type 2, a mixed monoclonal and polyclonal immunoglobulin, usually IgM in combination with polyclonal IgG. And type 3 is a polyclonal immunoglobulin. And why is it important to classify in type 1, type 2, type 3? Type 1 cryoglobulinemia is usually associated with B-cell lymphoproliferative disorder, such as chronic lymphocytic leukemia, plasma cell dyscrasis, and multiple myeloma. So it's something that I think we see in a lot of cases with multiple myeloma. And I remember that previously, it's something that we should be looking at actually. We should be checking. And then I think if we start most of patient myeloma, perhaps we should screen them for the cryoglobulinemia type 1. And type 2, type 3 cryoglobulinemia are often associated with chronic liver disease, autoimmune disease, and infections. Hepatitis C virus is common cause of type 2 and type 3 cryoglobulinemia. Again, I think maybe we have missed quite a few of them. Maybe we need to start checking for those stuff actually. And of course, cryoglobulinemia can also be classified by whether it's associated with underlying disease, as I mentioned already, essential or idiopathic cryoglobulinemia without an associated disease. Secondary cryoglobulinemia associated with disease such as an autoimmune disease, infection, disease, or lymphoproliferative disease. So type 1 cryoglobulinemia, how do they present? Symptoms and signs related to vascular occlusion. So they tend to really present with vascular occlusion by the cryo precipitate, such as digital ischemia, levator reticularis, and skin necrosis. And again, that can be mistook as to vasculitis. And again, if you don't have knowledge, if you haven't checked for cryoglobulinemia, you will miss the diagnosis. And most of these people will be treated as rheumatoid or as a systemic sclerosis, though they don't meet the criteria. So it's very important that, again, you need to think about it and consider it as one of the differential diagnoses. And the problem with them, they tend to be highly dependent on low outside temperature. And they will have also some skin manifestations are most common in those patients, are reported 7 to 85%. And then they will have what we call extracutaneous disease that includes peripheral neuropathy in approximately 20 to 45% of patients, arthralgia in 30%, and kidney disease in 30%. Renal phenomena is also a common occurrence. And again, that will probably lead to rheumatological conditions, and you forget about cryoglobulinemia. So again, I think rheumatologists probably are quite more alert than physician making the diagnosis. And then the mixed cryoglobulinemia with type 2, type 3. They present a quite very non-specific, and they tend to have constitutional kind of presentations with symptoms of arthralgia, fatigue, and malaise, as well as palpable purpura due to cutaneous vasculitis and sensory changes or weakness due to peripheral neuropathy. Metastriate or purpura arthralgias and weakness is seen in most of the patients, and purpura is the most common manifestation usually involved the legs, but can extend to the torso and upper extremities. Membrane proliferative glomerulonephritis is seen 20 to 35%. So you tend to, when there's renal involved, you need to think about type 2 or type 3. The treatments really for that is directed toward the underlying cause. And then looking at, of course, the early diagnosis of immunological cause of the diffuse alveolar hemorrhage, I think the time since of the first respiratory symptom very important, more than 11, and you can see the p-value. And then, of course, they tend to have, when they have symptom of fatigue and weight loss, arthritis, and proteinuria that can really assist you to make a diagnosis as early as possible. Early diagnosing immunological cause, of course, to look at the specificity and then the sensitivity and look at the area under receiver. So the earlier diagnosis, the easier. So diffuse alveolar hemorrhage, laboratory testing. So initial testing, of course, is to do to determine severity and rate of progression. Look for other organs involvement. Do blood count and serial HB determination. That's very important because dropping HB means the patient needs an urgent plasma exchange. They need to be in center where there's a critical care, pulmonologist, or intensivist to assist the patient, and also nephrologist. And sometimes time is really red cells. Serum creatinine and UKE, and then urinalysis and urine microscopy to look at the dysmorphic red cells to see whether the red cells originate from bladder or from glomerula. Specific etiology, of course, you look at ANCAs, need to be tested, ANA and anti-double strand DNA, serum complement levels, and anti-glomerular basement membrane is very important. And most of those tests will take between 48 to 72 hours. So sometimes you don't need to wait for the results. If there's good experienced clinicians, you can actually start treatment as early as possible. And steroids always tend to be a first line while you with a plasma exchange. And I think currently in South Africa, we have issue with albumin. So I think that's why it's very important to see one modality will be used actually for plasma exchange. Antiphospholipid antibodies, which is very important for mitoid factor, and anti-CCP antibodies. Preglobulins need to be done. Role of lung biopsy, I think, is debatable. I think you need to assess your patient carefully and see whether they fit for lung biopsy. And if the acute respiratory failure, I suggest that you don't consider it. You don't consider lung biopsy. You need to treat because biopsy might not change the outcome of the patients and actually increase mortality. So biopsy should be done on patients that are only stable. And I think there's a role of empiric therapy where you can give them actually your steroid, your plasma exchange, and obviously cyclophosphamide, and then consider biopsy in later stage. So diffuse alveolar hemorrhage, therapeutic approaches. Of course, we look at respiratory and cardiovascular support, which that's really absolutely very important. And I think, as I say, centers where there's intensivists, cardiologists, nephrologists have to be really with a subspecialty center. And then you need to correct coagulopathy if present. Again, you need to do your INR PTTs, and then also now you're having tools to do anti-factor 10A for your new oral anticoagulation therapy, and that can guide you. If that's very high, then you need to find a way how to treat them. There's antidote presence, and also there's other modalities that you can use to treat that. And then for those with immune-mediated diffuse alveolar hemorrhage, you can give a methylprednisone pulses from 500 to 1 gram for 3 days, and then you de-escalate. Plasma exchange, of course, if there's renal involvement, induction or remission, use cyclophosphamide or rituximab. The case report, of course, there are a few factors discussion about the use of factor 7A, and then aminocapric acid, and then also BB ECMO also being suggested as an option for treatment. And that's really my presentation. Thank you.
Thank you very much. It's quite an extensive topic that you've covered. Thank you very much. I don't know if there's anybody online or in rooms that want to ask any questions. see. It's this one. Also not going It doesn't, yeah, there are two people online. I haven't seen them.
Yeah.
Just maybe want to make a comment on the lab side for the cryoglobulins. You need to realize that the turnaround time is 7 days.
Okay.
That sample sits in the fridge and the warm bath for 7 days. The technologist and the pathologist inspects it every day for flocculation and precipitation, and only on day 7 a call will be made, it's present or absent. So it's not an immediate.
And how much sample do you need to draw actually?
We need to take EDTA samples and then serum samples. So maybe at least 2 of each, just to say that you do have a backup.
And then the hemosiderin latent hemorrhage, how do you actually make that? Because we know I'll give you samples of 60, between 50 to 60 mils of sterile blood. We start out on the sterile saline. Is that very quick? That's hematology, obviously.
Yeah.
So what we've done in the past, you just make a slide of your sample and you do an ion scan, and then you have to physically count.
Okay.
And that's very immediately, isn't it?
Yeah, well, within a couple of hours.
Will the urine hemosiderin be positive in those patients? Or hemosiderinosis?
No, it shouldn't be for hemosiderin. Yeah, because no. Well, it depends. Because most of these patients, because they would because depending on the etiology. Obviously, if you have renal involvement, they will have underlying hematuria. Yeah, so you might actually test it positive, but if it's not renal involvement, then you shouldn't have. Yeah, so maybe it might guide you to the etiology of the. Okay, thank you. Thank you guys for attending. Manda, any question from Brits?